Is he there? Yeah.
Arun is there, ma'am.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Hello.
Yeah. Thank you, Arun.
Yeah.
I request Dr. Shobha Gudi, madam, to please give the presidential address.
Not presidential address. I will just address the gathering here.
Yes, ma'am.
And
Yes, ma'am.
I wish that all societies must follow these flyers and join the webinars in time, so that they don't miss the very important initial part, because often when the speaker starts, a lot of information will be given in the first 5 minutes, especially. So the context is set right at that time. So I'm delighted, Prabha, that your committee is doing such excellent work. And Kasoga is very proud that this subspecialty of endoscopy is, growing by leaps and bounds. The interest generated, the kind of talks that you are having, the faculty expertise which you are bringing into Kasoga platform, it's really commendable. So today, we are really fortunate that Dr. Ameya Padmavar is with us to speak on the equipment, as well as Dr. Ravikant for the port side problems. And the interesting case scenarios will be by our expert, Dr. Prabha. Wishing you all the very best, Prabha, and happy learning to all Kasogians. And we are missing the president, Dr. Durgadas, but I am sure he is blessing the webinar, and he has already asked you to take it forward in his absence. So all the very, very best. All the very best. Yeah.
Thank you, ma'am. Thank you for your encouragement. Priscilla? Hello? Hello? Hello, Dr. Priscilla?
I'm online.
Yes, ma'am. Chairpersons have joined. Hello? Hello?
Yes, madam.
No,
Asha
hello,
madam
Prabha, I'm
also
there.
joined.
I'm there.
Yeah, yes, ma'am. Yes, ma'am.
Good evening. Good evening.
Hello, ma'am. Good evening, ma'am.
How are you, Prabha?
Yeah, I'm fine, ma'am.
Great.
So we are started with our webinar, ma'am. Very
Yes.
much welcome to the webinar. And now we are starting with the first talk with your chairperson's presence. So please introduce Dr. Amaya, introduce Dr. Asha madam. Priscilla.
Yes, ma'am. I'm just sharing the screen.
Yeah.
Yeah. Dr. Asha Neravi, madam, is the unit chief of OB-GYN department in STM, and she studied from MRMC Gulbarga. She's a very active gynecologist and a very good academic teacher. She's a very inspiring teacher to all the postgraduates. She's been the past president of Hubli Dharwad Gynec Society, and madam shows interest in high-risk pregnancies like diabetes and hypertension. She's also an active member of the Hypertensive Society. Over to you, madam.
Thank you, Priscilla. Thank you for your introduction. Should I introduce our today's speaker?
Yes, ma'am, the first speaker.
Yeah. I'm privileged to introduce Dr. Ameya Padmavar, who has done his advanced laparoscopy from Austria. He is an excellent and very meticulous endoscopic surgeon. When I watch his videos, he is alumni of St. GSMSC and Navi Naurogia Vadia Maternity Hospital, Mumbai. He has interest in advanced laparoscopy, gynae onco, and pelvic reconstruction. And it is we are very happy to inform everyone that he has designed a surgical smoke evacuator called as smoke guard, which is extremely important for our lab surgeon's health. He is a faculty of IMAST, and he is affiliated to many very well-known, renowned hospitals like NH Nandani, Godrej, MH, SLRH, Florist, and Khar Hinduja Hospital. Without much ado, the floor is yours, sir. We are very eager to listen to you, Dr. Amaya Padmavat. Thank you. Thank you.
Good evening, ma'am. Thank you for the kind words. So first of all, I would like to thank Dr. Prabha for thinking of me for this important topic. So when she called up and told me that we have to address the gynecologist of Karnataka State Obstetric and Gynec Association about the sterilization and care of hysteroscopy and laparoscopy instruments, a lot of thoughts came in my mind, and I tried to compile what is my thought process about it. So I'll just share with you my presentation. So when it comes to hysteroscopy and laparoscopic instruments, in the beginning of my career, we used to place these instruments in a transparent acrylic chamber, which contained formalin tablets and were assumed to have been sterilized with these vapors. But the reality struck in soon, and there were some port site infections, and patients would take longer to recover, and that made us think and educate ourselves about how to take care of these delicate instruments and how to sterilize them. So before we start with the sterilization part, I would like to just highlight certain points, because Dr. Prabha told me that we have to have a lot of practical points which you can take home at the end of this session. So when it comes to the most important part on our trolley, the telescopes, you have to know how to handle these delicate instruments, because any impact on them is going to distort their optical axis, and hence the vision is going to be spoiled. So when you're carrying your scope over your trolley or taking it to clean or whatsoever, you have to always support it by its eyepiece. Eyepiece means the ocular piece where the camera gets connected to it. And never keep it without its casing, especially in the sterilization chamber, because when it gets sterilized and the impact of adjacent instruments on it can cause damage. The same thing carries when you keep it on your trolley. You should always keep it not covered by any other instrument. And at the end of every procedure, you have to first wipe it with a gentle soap solution or a Savlon betadine or a beta scrub solution, and wipe it dry with a neutral pH enzymic solution. And all this is finally washed away with the use of distilled water. Mind you, I'm saying distilled water. Do not use saline when you finally rinse your scopes, because saline, when it dries up, will leave behind a coat or a layer of salt, which will obscure your vision and make it a little difficult in your next application. Next comes the fiber optic cables. I'm only highlighting those parts which I feel should be brought to the attention of this audience. So when it comes to the fiber optic cables, these are a bunch of quartz fibers, and they are packed inside a armored sheath. And you cannot bend it at extreme angles, because if you bend it, the fiber gets fractured, and one fractured fiber means a fraction of the light transmitted to the optic will be reduced. If there's no light inside the abdomen, nothing gets reflected back, and hence your vision is going to suffer, however great your camera may be. So you should always store it by making big circles of the cable, especially when you're storing it. It has to be in a wide round container. Avoid making hairpin bends on it. Whenever you're rotating the cable, especially when you're using the 30-degree or the 45-degree oblique scopes, you have to hold the steel part of the cable, the connector, and rotate it, and not the gray or the green part of the cable and twist it, because otherwise it will get fractured. Whenever you are fastening it with other cables over the patient's legs or the abdomen, always use a gauze piece to tie all the cables together and then put a clip on it to fasten it to the drapes, but do not use a clip directly on the fiber optic cable. Ensure that both ends of the cable are clean so that the light transmission is maximum through its reflective and polished surface. At the end of it again, at the end of the surgery, wipe it with a soap solution and remove all the blood and organic materials at the end of every use. Of course, when it comes to electrosurgery, it is used on almost all our instruments except the needle holders. So you have to see and inspect the insulation of these instruments. The black colored instrument, the black is the actual insulation sheath. Okay, it is a heat resistant sheath and it is housed over the steel portion of the long instruments, and physical insults or instruments rubbing against each other or using inappropriate current through these instruments causes damage to its surface. And when the current jumps through these small breaches, it causes more damage. So especially like there are different zones of the instruments which have been described from where these electrosurgical leaks can occur, especially the one from beyond the jaw to the handle of the instrument is the one which is actually not seen while doing the surgery. And any breach in this insulation is going to cause leakage of current and damage. But only the physical inspection will detect only a few breaches, especially when the rent in the insulation is large. Otherwise, it is very likely to get missed out. So your CSSD department or the biomedical technical team should inspect the instruments once in every week or once in a fortnight, depending on the number of surgeries which are going on in your institution or hospital. So let's come to finally the sterilization of laparoscopy and hysteroscopy instruments. Now, when thinking about it and reading about it brought to my attention several steps. So I've tried to put them in an organized way to understand how to use these instruments. So at the end of surgery, when you get your instruments, they have to be kept ready for the subsequent surgery. So first thing is the decontamination. After the decontamination means you get rid of all biological material from the current set of instruments. You have to dismantle them. So when you're choosing your instruments, you should choose instruments which can be dismantled easily. If you cannot open these slender, lean, coaxial instruments, it is difficult to get rid of all the biological material. And it is going to have an impact on your subsequent cases. Then comes the step of pre-cleaning, followed by cleaning and rinsing of the instruments. After this, if your center has something known as ultrasonic cleaning bath, it is a great adjunct to the whole assembly, because ultrasonic agitation of fluid with the instruments therein will dislodge all the biological and organic material from its joints and make them clean. After doing all this, you have to dry them. The instruments have to be dry, because if you autoclave them, the solution is going to harbor some spores and some organisms, especially atypical mycobacteria. So drying of them is very, very important. After drying, organized packing, assembling and packing of the instruments, then they go in for the step known as sterilization. Okay, so you have 7 steps followed by the final onslaught with something known as sterilization. Okay, and then the last is storage. So after you sterilize them, you have to wrap them up in a set of non-porous drapes and keep them in your CSSD department away from moisture and humidity, so that they can be used at the appropriate time. And another thing when it comes to the storage is labeling them. So what is the set containing? So there has to be a standard name or a standard set which you have allocated, and the list is displayed in the department. And it has to have the date of autoclaving or sterilization and the date of expiry of the said set. Okay. So let's understand what is meant by these levels of sterilization which are required when you're embarking on laparoscopic or hysteroscopic surgeries. So here there are three levels which have been defined. That is the high level sterilization, in which all life forms except spores are destroyed. Spores, the bacterial spores, are a little difficult to tackle. They are very heat resistant and hence cannot be easily destroyed. Then comes the intermediate level, where some fungi, viruses, and spores are spared. And the low level, as I told you, when we started our practice, we would use formalin chambers. And this is known as a low level disinfection, where is fungi, viruses, spores, and mycobacteria remain undestroyed. So you think your instruments are sterilized, but they are highly dangerous to the next patient undergoing the surgery. So what we are going to focus our attention is on the high level disinfection. What are the challenges which we encounter when we deal with these thin, linear, long instruments? They are having a complex design. They have many small, intricate parts, and the grooves in these instruments are so small and are very likely to harbor the blood and proteinaceous material, making a good substrate for microorganisms. Especially hysteroscopy instruments, the 5 French instruments are very lean. So when you say 5 French, you have to divide it by the factor of 3 to know the actual diameter of these instruments in the metric system. So 5 French would be around 1.6 millimeter in its outer diameter. So 1.6 with a moving part is going to be very thin and lean. And obviously these instruments cannot be taken apart and they are difficult to clean. So many times when we are doing hysteroscopy, we see that, you have brought in a clean sterilized instruments, but then you have at the hinge point, there will be rusting because the steel may always not be of the appropriate purity, which is required to make them free of rust. If they are rust free, they are going to be really, really pricey. They will be the price of, something like the price of gold, they are so expensive. So very important to keep them away from rusting. Second thing is the positive pressure pneumoperitoneum. It drives all the fluid blood up the inaccessible parts of the instruments where it gets dislodged and it, eventually becomes a site for further harboring of the organic material. Then you have the clocking of the flush ports. Flush ports mean these are ports which are available in the instruments which allow you to flush out all organic material, especially when it comes to needle holders or instruments like the PCOD needle. They'll have a flushing port through which you have to inject water or saline to get rid of all the proteinaceous material. And most important, you cannot use scrubbers on these instruments as you use in open surgery instruments. If you have seen your technical team clean the instruments after you have finished with the surgery, they use a standard scrubber which is used for cleaning utensils. And such scrubbers, we cannot use them on the laparoscopy instrument. So let's go through these each steps in short, so that we understand how to keep them ready for sterilization. First thing is to take apart all instruments after surgery and soak them in water. Okay, so you have to dismantle them and soak them in simple water, plain water, tap water, take it in a tub and soak all the instruments in this. If the instruments are not dismantled, we cannot get rid of the blood, debris, and the microorganisms. Hysteroscopy sheets, especially the resectoscope sheets, they have multiple valves and knobs. So these have to be dismantled before you clean them. So your team has to be aware that all these valves can be taken apart and they are tiny, tiny parts. So you cannot have them open out in the sink, because if these little parts go down the sink, you are going to be faced with a problem for the subsequent case. They are very, very small. So better done on the surface of a trolley or inside a big broad tub which is long enough to accommodate all the dismantled instruments. After you have dismantled them, it is a good practice to soak them in 0.5% hypochlorite solution for a period of 10 minutes. Hypochlorite is basically the bleaching powder solution which was recommended for all your seropositive or HbA/Ag positive patients, or where you don't know, whether the patient is infected with any communicable disease. So in these cases also, hypochlorite is a wonderful solution and it kills almost everything. So, but you cannot keep it longer than 10 minutes because it is going to be a little harsh on your instruments. It is going to release the chloride radicals, which can cause damage to the finest of steels. You can use a ultrasonic cleaner again at this stage. I'll show you a picture of this ultrasonic cleaners. Generally, when you choose the ultrasonic cleaners, you should choose those which have a tray which is at least 30 centimeters, 35 centimeters long, so that it can accommodate even the unassembled or partially assembled laparoscopy instruments. Okay. If your center is catering to the bariatric surgery as well, these instruments are 42 to 45 centimeters long, and you will need a longer tray. Okay, so this is very important, the decontamination part. Then it is known as something known as the pre-cleaning. Now, after the decontamination, the instruments have to be soaked in a enzymic solution, because these enzymes, these proteases, lipases, there are many commercially available brands. Cytozyme is the one by J&J. I'm not endorsing it, but that is what is used in my center. So when you soak these in the requisite amount of the enzyme solution, it breaks down the blood and other proteinaceous material, and they can be removed with thorough cleaning at the end of it. So that's the pre-cleaning part of it. So this is how yeah, the CSSD zone. Okay. This is where all our instruments are processed. So you can see a big tray with two taps, which are used for cleaning and washing of the instruments. On top, you have a shelf which has a tray which is used for soaking or the pre-cleaning instruments. Adjacent to that, you can see a bottle with a green label, which is basically Cytozyme. Okay. And next to the long tray where you have the cleaning taps is the ultrasonic cleaner. This is the size of the ultrasonic cleaner which is useful. And then you have the storage area. This is how a standard, this is how we use it in small nursing homes, such as my setup. Okay. And then the cleaning, especially when it comes to the cleaning of tubular instruments, the cannula, like here you can see me use this long brush to clean the inside of the trocars and the tubular instruments such as the suction cannula or the shafts of any laparoscopy instruments. It is very important to use these brushes. Sometimes you can use the air jets or water jets also. We have a small such unit. I will show it in the subsequent picture, which is a small unit which generates compressed air. And this compressed air can be used with a jet to clean the inside of all these tubular instruments. Okay, so that's about the ultrasonic cleaner. So that is the ultrasonic cleaner. The ultrasonic cleaner has another addition to it. It has got a heating coil which increases the temperature up to 70 degrees Celsius and can be used for your outdoor instruments cleaning. Mind you, the ultrasonic cleaning is 16 times better than hand cleaning. So do not ignore the value of this cleaning device, and it is not very expensive. And every center which caters to more than one laparoscopy or a hysteroscopy procedure in a day should have this. Of course, after the cycle, you have to clean all these instruments with running water, because water is something which is going to reach into every channel and groove and get rid of whatever has been dislodged. So then comes the drying part of the instrument. So this is how we have this small air compressor in our clinic, and that's how we use the air jet to get rid of all the moisture from inside of these small tubular instruments. On the right side, you have a tray, especially this is made by one of the centers which makes, or one of the vendors which makes kitchen trolleys, you know. So these are steel sieves and trays. So in this, we can hang up all our instruments, especially instruments which cannot be taken apart. As I told you, the needle holder, the 5 French instruments, the sonicision probes or the tackers, which you have cleaned, but you cannot dry them. So you have to hang them upright, upside down. A very good practice of drying hysteroscopy instrument is after the procedure, hang them up on your IV stands, because you cannot get rid of water which stays inside these thin lean instruments by capillary action. Air drying, if you have such a small, this is a very cost effective compressor, but there are larger compressors which are available in the CSSD department, and they clean the inside of instruments very, very easily. It's a good adjunct to every laparoscopy center. Okay, then comes the main step, which I am going to talk about now, is about the sterilization. Sterilization of laparoscopy or hysteroscopy instruments is done by 3 or 4 methodologies. One is the steam sterilization, known as autoclaving. You have the gas sterilization, which uses ethylene oxide gas. Then you have the high level disinfection, which uses fluid chemical sterilization. Also not very strongly recommended, but sometimes, especially when it comes to optics and electrosurgical handpieces, it is a good way of sterilizing them. But you have to know your chemicals properly so that you can use it appropriately. And last but not the least is the plasma sterilization. Plasma sterilization is a boon. And in the pictures, you can see that's how we lay our instruments out for drying. This is a standard set for any laparoscopy procedure. And then we pack them up in such aluminum perforated containers to be assembled just before the next surgery. So most important is to autoclave these instruments. Now, when it comes to choosing the autoclave, always choose a horizontal autoclave for your laparoscopy instruments, because the horizontal autoclave ensures that the instruments come out dry than the vertical ones. So it is a useful tool and available in every medical setup. Only for laparoscopy, you need the appropriate size. So this is the one which is available in our office, and the containers must, after the autoclaving cycle is over, the containers must rest for at least 45 minutes. So this ensures the drying of all the instruments and prevents the condensation of vapor on the lens of the optical instrument. The standard steam autoclaving involves heating up the steam to 121 degrees Celsius at a pressure of 21 psi for 45 minutes. Okay, this is a standard protocol and is sure shot and works for most of the laparoscopy and hysteroscopy instruments. Then sometimes in some centers, they have something known as the flash sterilization. Flash sterilization requires a separate machine which can increase the pressure of the chamber to 30 psi, and the steam is heated to 135 degrees Celsius, and this takes 4 minutes. Okay. And of course, the post vacuum and dry cycles are required. So it takes a little more time, but it is faster than the conventional autoclaving. Then there's one more way of steam sterilization which uses formaldehyde vapors at 55 to 80 degrees Celsius, and this exposure is for 6 hours. Not recommended, because formaldehyde is harmful to the health of the healthcare professionals and is carcinogenic. So, but it is very useful for tubular structures. So it cleans the inside of these tubes as well. And especially those which cannot be heated up, it is a modality, but not to be, I do not recommend that for any of it. Then comes the ETO, the ethylene oxide gas sterilization. Now, ethylene oxide gas is very useful, but you should have enough instruments or enough number of packets to go in the chamber so that it is filled up, so that you can make the most of the value of the canister of ethylene oxide which is being used. So it uses at a lower temperature of something like 37 to 63 degrees Celsius is all that is required. So instruments which are heat sensitive, such as of course, I do not recommend the reuse of harmonic probes or single use instruments, but to make them more cost effective, you have to appropriately sterilize them, and ETO is a great modality for doing in-house sterilization of these instruments. So it uses ethylene oxide gas, which is 8.5%. There are two formulations available of the canister, and they work at a humidity of 40 to 80 percent humidity and a temperature of less than 60 degrees Celsius. And the instruments are exposed for 4 hours, 4.5 hours. And after the cycle is over, the instruments have to be aerated for about 12 hours. Okay, so the only drawback of this is that being an environmental hazard, the aeration time is 12 hours. So the instruments, what you give on a Monday, are available for use on a Wednesday. So that is what one has to remember, that you cannot reuse them immediately the next day. Okay, and aeration is an important step which cannot be bypassed. So that's a little drawback in the whole game. Then comes the chemical disinfection. Now, why disinfection and not sterilization? Because it eliminates bacteria, fungi, and parasites, and it is not very reliable on spores and atypical mycobacteria. Remember that when you are using Sidex, that is 2.45% glutaraldehyde, which is available in all your ORs. You have to understand that once you activate this solution, it stays active for a period of roughly 14 days. Do not use it on the 15th day. It is ineffective. Even if you have used it only once, still it has a shelf life of only 14 days on activation. Okay. After that, you cannot use it, and you have to make a new set of solution for the subsequent case. The high level disinfection, again, when you reuse the same solution again and again for subsequent cases, depending on the microorganism load and the presence of residual proteinaceous material, if the solution gets cloudy, you cannot see the bottom of the container through it very well, then you have to change the solution. Okay. And there are certain strips which are given by the supplier, which have to be dipped in the solution in the beginning of the day to know whether you can use it through the day. So it is a good practice to use these indicator strips, and do not, I'm telling you, do not reuse this solution if it has become hazy or cloudy. Okay. So you have the options in the form of 2.45% glutaraldehyde, or aldehyde free, something known as orthothialaldehyde, that is 0.55%. This requires lesser time for disinfection and is a little bit expensive, but for fast disinfection, it's a good modality. Then you have para-acetic acid, also known as Parasafe, in which you are using reconstituted solution using this para-acetic acid, which comes in a powder form. So for people who are going from one center to another, this is a very good boon. And the activated solution can be used for 24 hours. Again, immersion time is at least 10 minutes. For glutaraldehyde, it is at least 20 minutes. And for total sterilization, means if you want to get rid of the atypical mycobacteria, the immersion time is at least 60 minutes. That is 1 hour. Orthothialaldehyde gets rid of all the mycobacteria in 12 minutes. So roughly, if you are going to use any of these immersive solutions, you have to dip your instrument for a period of roughly 20 minutes. Okay. So this is the glutaraldehyde canister for one set of, when you're using the type of steel tray, which I showed you in my CSSD department, we have to use at least 5 liters so that all the instruments are appropriately immersed. The instrument has to immerse, it has to be submerged under the upper meniscus of the fluid. Okay. And the important thing I would like to bring your attention is using the indicator strips before use every day. The most versatile modality of sterilization is plasma sterilization. Now, plasma sterilization commonly marketed initially in our scenarios by J&J under the brand name of Sterad. Now, what is this plasma sterilization? Now, if you see in autoclaving, you're using high temperature, you're using thermal energy to get rid of all the live bugs. Here, you're using something known as the intermediate state of matter known as the plasma. Okay, so hospitals with high workload require rapid turnaround times for instruments. So, Sterad is a good way in which you can get instruments sterilized in 75 minutes. So it is 1 hour, 15 minutes is the cycle. And how does it work? So basically, when the instruments are cleaned, dried, and packed and kept on the shelves of this huge machine, 59% aqueous hydrogen peroxide is vaporized into the chamber. After that, the pressure in the chamber is reduced. So when the pressure is reduced, at low temperature, the gas or the fumes of hydrogen peroxide go into a state of intermediate state of matter known as plasma. Then radio frequency energy is activated in this plasma state, and this causes release of oxidative reactive radicals from the hydrogen peroxide, which react with the materials and each other, and basically they render all live substances inactive for infection. Means it kills all the viruses and bacteria, and and at the end of the last step is basically the dehumidification, that is the drying of all instruments. So all your instruments are dry when they come out of this cycle, and you cannot open the door until the cycle is over completely. And the sequel of this sterilization modality is water vapor, oxygen, and non-toxic radicals. So it is environmental friendly, unlike glutaraldehyde and the ethylene oxide, which are biohazards. Okay. So at the end of all this sterilization exercise, you have to have these instruments which are double wrapped in non-porous material, or you can have 2 layers of sterile drapes over it, and with a label which says that it has been sterilized by so and so on a particular date, and the validity of the sterilization. Storage has to be in wire trays, which is clean and free of humidity, and the temperature of the storage zone is to be managed. So it has to be well aerated as well. And if any of the packs are opened, even to check what is inside, you have to re-sterilize them, because you cannot reuse them. The moment there is breach in the outer cover, or the outer cover is opened, you have to re-sterilize them. So as I wish to end this discussion, I would recommend autoclaving of hysteroscopy and laparoscopy instruments as the preferred modality, and which is available in every center. Ethylene oxide is a good option for optics, reusable instruments, and hysteroscopy instruments and camera heads, especially sharps. Scissors go blunt when you re-autoclave them, so you can send them for ETO. Plasma sterilization is the gold standard, which is rapid, and it's a safe modality for all kinds of laparoscopy instruments and hysteroscopy instruments. Mind you, before I conclude the discussion, is that you have to check the validity of each sterilization modality. Okay, so you have to use a biological or a chemical indicator at a fixed time based on the protocol which you're following. So the sequential testing of the sterilization cycles is to be checked. Weekly cultures of 3 consecutive cell cycles are to be used and sent for culture growth. So that is the way how you audit your sterilizing modality. And this is what is followed by most of the CSSD and the CDC guidelines. So use such indicators, especially the type 5 or type 6 indicators are the ones which are to be used. And biological indicators, of course, you have to send them for culture at the end of it. So they have a color display. As you can see in the picture, these tubes will have the spores which change their colors at the end of the autoclave cycle. But of the 3 cycles, the the intermediate one, those those tubes have to be sent for culture. And if it is a negative culture, you're good to go. Otherwise, you have to find out the problem in your sterilization modality. Okay. So thank you. And I'm ready to answer any questions should there be any queries by the delegates.
Sir, it was an excellent talk. Just I wanted to know what is the cost of plasma sterilizer?
See, the plasma sterilizers, they are a bit expensive, but I think
Yes.
the indigenously manufactured ones are costing around 12 to 14 lakhs,
No.
depending
They killed
on,
yes.
in one of the centers we purchased it, it was for 12.5 lakhs.
They kill the spores also, sir.
Come again?
Spores, they will
The
kill the
spores,
spores.
yes, they are destroyed by plasma sterilization.
Priscilla, any questions?
Yeah. Hello.
Yes.
Yes.
Good evening. Good
Good
evening,
evening, sir.
Amya. Yeah. Prabha, it is nice to see you all.
Yes, sir.
Maybe.
Thank you, sir.
Yeah. I will like to just add this thing. First of all, I will next in visit. I will visit your center and will see your sterilization system. What we use in a small setup, we use hair dryer. When in a small setups, we put some jet for this thing air drying. And in our medical college, what we use is the airline, medical airline. We have put a jet to make it dry.
Yeah,
So
that is the
Yes,
same
yes.
one. Being in a smaller setup, we have a small compressor in our department, but otherwise they have a big
Central compressor.
compressor, which is
Yeah.
generally kept in the basement of the hospital in the parking area, and it is connected by a pipe to the CSSD department. Yeah.
or otherwise, in small setups, a simple, a good hair dryer will serve the purpose.
Yes. Yes, sir.
Yeah.
Sir, sir, what do you tell about the freelancing surgeon, sir? Amaya, sir?
Yeah. So to
Freelancing
just,
surgeon.
make a disclaimer, I am a freelancer. So,
You bring your own sets, I know.
Yeah, about 10 years ago, we had a spurt of port site infections, and we went into the depth of all these things. And what I did was buy multiple sets of instruments. So what we do is, if we have 4 surgeries, we will have 4 sets of instruments which are autoclaved and kept ready with us. And only the optics are used by chemical disinfection. We immerse them in Parasafe or Sidex. See, there are many other chemicals which are there. Corsolex, you can use Corsolex as well. So these in Corsolex, I'm telling you, it is a bit corrosive, so you cannot immerse it for more than 10 minutes.
Okay.
Remember that over a
Yes.
period of time, especially when it comes to hysteroscopy gear,
Mhm.
the valves will start leaking because
Okay.
the valves are generally made of something known as brass. So brass is a softer material than steel.
Still.
The ones which are made of steel generally last longer and then they don't leak. So it depends on what is your gear. If it is all steel, then you may not have this complaint.
Okay, sir. Very nice practical input.
Dr. Prabha,
Yes, sir.
just I will also like to share my experience as a freelancer.
Yes.
Now, when I was in Assam, I used to come to operate in Rajasthan all the way.
Okay. Oh
Okay.
my God.
And when I am now settled in Rajasthan, I still go to Assam for operating. So the best thing what I have observed is the ETO. If you can, this thing,
Yeah,
you keep a whatever the number of things you keep that ETO instruments open, and that remains the best.
Correct,
Previously,
correct.
when we used to formalin chamber, that this problem was very frequent.
Yes, sir. Yes, sir. As Amaya said, they are increase the number of hand instrument sets.
Yes,
So
exactly.
that is the solution for that. Yeah.
And
And I'm telling you, just to highlight, the Indian instruments which we are using, most of the instruments are all Indian. They are
Correct.
indigenously made and they are re-autoclavable. They are cost effective. Unlike,
Okay.
for if you have to buy 2 instruments by Carl stores, you can buy a whole damn set of instruments by Indian manufacturer.
Correct,
So
sir.
please do not
One
desist the use of indigenous instruments. They are very good.
Correct.
one more thing, like nowadays all the instruments are inserted separate and this thing. Previously, all the instruments, even particularly bipolar was cleaning was very difficult. Nowadays we have got a very good bipolar with a separate insert, so cleaning is better. And
Yeah.
with that we have
You should
that our
choose
instruments.
instruments which you can dismantle, sir.
Yeah.
Sir, what about that enzyme solution you are selling? You use it in like how endoscopy surgeons dilute with some.
Yeah, so every manufacturer will give you the reconstitution,
Okay.
and you have to use that. Generally, it is 1:20 or 1:30.
Okay.
Okay, so 50 ml of the solution can be used in 10 liters of water, and
Uh-huh.
you can keep the instruments for 10 minutes in it.
If you produce today 2 liters,
One,
you
one,
can
one day only. No, it
one
is.
day.
Yeah. It is generally made in 10 liters because 10 liters is a significant volume in which generally one set of instruments can be immersed appropriately.
If suppose solution remains, you cannot keep it for tomorrow.
No,
No.
it is not advised to reuse it. Of
Okay.
course, you have the cycle of sterilization after that. So,
Yeah.
but
No, means
if
that
you are
effect
using it
of
more than
dissolving.
yeah, so as a thumb rule, what we decide is after 2 cycles of immersion, we don't reuse it.
Okay, sir.
Hmm.
Yeah. Thank you, sir. It
Thank
was
you.
wonderful discussion and very practical approach because most of the surgeons are, one or the other port site infections they face, and then they go and then audit their sterilization methods and all. And there are new and new sterilization techniques are coming and all. You have highlighted all the methods by your so much of vast practical experience. Thank you, sir.
Thank you. Thank you. Thank you, all the members
And
of KSO GA. Thank you.
so, and I one thing I want to special thanks to Amay sir because 4 days back he was down with fever. Still he has
I know
accepted
it's
one
okay.
thing, and then he made this very wonderful insight, sir. Thank you, sir. Thank
Thank
you.
you.
Yeah.
Thank you, Amaya sir, and thank you, Asha madam. Let's move with the second topic. Our chairperson for the second topic is Dr. Vijay Nahata. Sir is a director on Department of Endoscopic Surgery in MGM College and Hospital, Jaipur. He has a lot of laurels to his forte. He's a founder secretary of SR in Northeast, a founder chairperson of IAG of Rajasthan chapter, and a voracious academician and a freelancer, as he said. Over to you, sir.
Yeah. Prabha, it is a lot of thanks for inviting me on this very interesting topic. And I cannot say proudly, but I think among all these participants, I am there who has faced maximum port infections.
Yes, sir. Actually,
Because
as we had discussed, you are the ideal person. That's why I told you to chair
due
this
to I
session.
could not.
Yes, sir.
Yeah.
Yes,
So
sir.
what I will tell you, once you face the port infection, you feel like that you will never do because it is equally troublesome for the patient and the doctor when patient is repeatedly coming for the dressing and you cannot help her. So you feel like that why I did laparoscopy? Why should I do laparoscopy? I will go to open but again one thing in open also these atypical mycobacterium is not uncommon. Then
Yes.
we have to search this thing, and there are two things just I will like to share. When I had my training in Melbourne with the Peter Maher, so there at that time these apple trocars. So there was the one use and they just throw it. So I just requested you give it me. So he made a special letter that this is for research purpose. He can carry out to India. So I brought a big, big,
Bun.
big carton of all these apple trocars. and we used it, but the cleaning was as, I mean, that was not that perfect. Sterilization, we were used to using a formalin, and that you cannot autoclave. We faced a lot. Another we faced, I conducted IAG sent this central annual conference in Guwahati. So in that hospital, all of this thing, around almost 50-60 delegates came in the OT. And out of 15 surgeries, 10 patients had this spot infection in that workshop.
It's
So
so
that was the
horrible.
two things, and it is really horrible. And now this thing is gradually coming down and down. So yeah, that's what my particular thing I
Yes,
wanted.
sir. Now you have to introduce Dr. Our today's speaker, Dr. Ravikant Gaudar, sir. Please do.
Yeah,
Yeah.
Dr. Ravikant is a professor OBG in KBG Medical College, Sulia. He is
Yes,
a
sir.
treasurer KIZ 25, honorary secretary IMA Sulia, Karnataka, then chairperson endoscopy committee. I think Karnataka is a very, very active. Authored a chapter on practical guide to third trimester of pregnancy and the Foxy Achiever Award 23. Yeah, sir, you are looking much younger, but and teacher par excellence, yes, and Yuva Sadhaka Award 24. And then area of interest, pelvic endoscopic surgery, endometriosis, infertility. Sir, please go ahead with your presentation.
Yes,
Thank you,
sir.
sir. Thank you, sir. Thank you so much for that nice words, sir. Yeah. Good evening to all. Respected, just share my slide.
Yes, sir. Yes, sir. It has been shared, sir. Yeah.
Yes. Good evening to all. Respected President of Kasoga, Durgadas sir, and Secretary Shobha Gudi madam, and even Asha madam is also there, Press Secretary. Our Chairperson of Endoscopy Committee, Dr. Prabhat, a very active member. She is doing wonderful job. Very dynamic now. Very good. And today's topic is also very basic, and everybody wanted to know about it. And our previous speaker made a justice to it. Dr. Ramaya did very nice, and how he showed himself how his hospital is doing it, and he gave all the practical examples. That was very wonderful. So I am going to talk on port site infection prevention management strategy. We are going to discuss under these causes and types of port site infection, evidence-based prevention strategies, how to diagnose them early and treat effectively. And most important part of the topic is, as sir was mentioning, that identifying the atypical presentation. So minimally invasive surgery, laparoscopy has the advantage like shorter hospital stay, lesser morbidities, and early resumption to activities. But if any of these complication happens, it nullifies all these advantages. So that's one the patients will be very much discouraged. Why did I go for a laparoscopy? So we should be very careful. And being a India in a tropical country, it attracts most. Whenever there's a contamination is there to the site of a surgery, there is going to be colonization and there will be increased chances of infection because of Indian tropical country. The incidence is varying from 0.2 to 7.2%. There's a lot of variation is there. It's mainly because of the how much standard we are keeping in our setup. Even cleaning the instruments, sterilizing them, and using them. And even while doing the surgery, what are the various practice we are practicing? All these will affect our management. According to CDC, port site infections have been divided into early and late. Early means if an infection happens within a week, and late means if an infection happens after a month. They are also been divided into superficial, deep, and organ space. Superficial if it is only skin is involved. Deep if a subcutaneous tissue is involved. Organ space means whenever there's underlying structures like uterus or even the peritoneum if it is involved, then they use the word organ space involvement. Causative organism also changes. If it is early, most of the time it is gram positive or gram negative. Gram positive organisms most commonly will be streptococci and staphylococci. Gram negative, most of the time, E. coli, Klebsiella, Pseudomonas. Sometimes proteus infection, especially if a necrotic tissues are present, then there can be proteus infection also is possible in immunocompromised persons. Late onset, if infection develops after 1 month, atypical mycobacteria is the commonest organism. Mycobacterium fortietium and Shilloni are the most commonly seen. What are the risk factors? Why few patients develops these port site infections in spite of all the efforts to prevent these infections? If it is uncontrolled diabetes or marginally controlled diabetes and obese patients, definitely they themselves independently increase the risk of port site infection. Immunosuppression due to various reasons, maybe recent viral infection, or a person is on steroid for some other reason, or any other reason. If it is immunosuppression is there, even the normal commensal starts growing. Surgical factors like contamination. If any small asepsis means asepsis is happened during process, or if an assistant is not properly trained, it can happen that there can be breach in the sepsis that is supposed to be maintained during surgery. Or if a surgery lasts more than 3 hours, the chance of infections are more. And if any fault in the sterilization process are all maybe the risk factors. Hospital factors like, as sir was mentioning, that apple trocars, they are very good. They should be used once and should be thrown away. But due to the cost effect, especially in India, we try to reuse. So whenever we try to reuse, they should be properly cleaned, all the brakes, all the screws, and every part of it should be properly cleaned, air dried, and there should be autoclaved. Only then it should be. And WHO recommends this cleaning process should be using a reverse osmosis water. So that especially as Dr. Ramaya was mentioning that even Indian machines are also very well effective. And if you buy these machines, imported one, they'll be very expensive. But reverse osmosis nowadays, Indian mates are very, very easily available. They work equally better. And if you are able to use a reverse osmosis water for cleaning the surgical instruments for all purpose, they themselves will reduce the chance of infection, and especially most importantly, the atypical mycobacterium are very, very less. So what are the preventive measures? What can be done to prevent? How can we prevent them? So WHO checklist integration is very, very important. It not only prevents the port site infections, and it is not only for the laparoscopy, it is for all surgeries. That I'm going to share it in the next slide. That is easily available in the net. So that is very useful in preventing almost all sorts of complications that can happen during surgery. As Dr. Amaya was clearly mentioning, that cleaning the instruments very, very important. Hair clipping favors and it prevents the chance of infection, and hair clipping should be done just 3 hours before the surgery than doing overnight. Even shaving should be avoided as much as possible. Antibiotic prophylaxis, antibiotics, cefazolin is advised, or cefotaxime 1 gram is advised. They cover both gram positive and gram negative organisms. And the most important is the timing when we are going to give antibiotic prophylaxis. It should be given 30 to 60 minutes just before the incision. Meaning at that time, the plasma concentration of the antibiotic should be well enough to prevent the entry of microorganisms. Even if they enter, these organisms should not attach to the receptors. If they are not attached, they are not going to be colonized. They are not going to grow. So that is the idea of maintaining the antibiotics. That is very, very important. Not only the choice of antibiotic, timing is equally important. The best timing will be when the induction of anesthesia is done. That is the best time to give antibiotics. So this is the surgical safety checklist that is easily available in the net. It gives before the induction of anesthesia, what are the checklist you should be followed before taking the incision, and when the operation is completed. So it will, if you follow this, it will be useful to prevent most of the surgical complications. During surgery, we clean the surgical site and then paint it. So most of the time we use povidone iodine or chlorhexidine. Chlorhexidine is preferred over the povidone iodine, but there are studies that have shown that povidone iodine is also equally effective as chlorhexidine is little more costlier, especially when you're talking about an Indian scenario. And the most important part of cleaning and painting is at least 3 minutes should be allowed for air drying. Once there is a air dried, then when the contact time is properly allowed, most of the pathogenic organisms on the surgical site will be sterilized. So again, single-use trochars are being re-emphasized when compared to reusable. If you are going for reusable, it should be going for a autoclave. They should be properly cleaned, completely autoclaved. Even the duration of autoclave is also should be properly mentioned. Sometimes it happens that it is autoclaved, but we don't know when it was dead. So properly date also should be kept, and then it should be used properly. During surgery also, use of excessive energy source also increases the chance of surgical site infections. So excessive use of energy source will lead to necrosis of the tissue, which attracts infection. And even the smoke evacuation, if it is regularly evacuated during surgery, it not only improves the vision of the surgery and you can do a proper surgery without injuring the adjacent structures, it also reduces the chances of port site infections. So nowadays, smoke evacuators are also available, which have a negative suction. They detect immediately the smoke that is seen in the doing surgery, and immediately they will activate and regularly they evacuate. They are also available. They are effective. In the post-operative period, if any incision is there below the umbilicus more than 7 millimeter, above the umbilicus more than 10 millimeter, they need to be approximated properly. And they need to be checked 24 to 48 hours after the surgery to see if any early signs of infection, if it is present. And the patient should be advised to maintain the hygiene in the post-operative time. So how are you going to identify if an infection happens? Suppose if there is a mild erythema, if it is present, or induration if it is present, or if a purulent discharge is present, so that should be differentiated from a suture granuloma. If it is a suture granuloma, usually erythema and induration will not be there. Just a pink granulation tissue will be present, and patient will not have any signs of infection. And if it is a subcutaneous tissue is involved, that needs to be treated separately. Most of the time, complete blood count, ESR and CRP is sufficient to make the diagnosis along with the signs of infection. And if infection is present, better to take the wound swab and send for culture. And if there is a late infection is there, more than 1 month, you should always make a practice that most of those cases should go for AAB staining and culturing to remove the chances of atypical mycobacteria. Ultrasound may be necessary to confirm deep and organ space involvement. Otherwise, superficial infections, most of the time, ultrasound may not be necessary. But ultrasound is sufficient, and no other other adjunct investigations may not be routinely necessary. Suppose if it is a mild infection is present, just antiseptic and cleaning is sufficient. If there is only superficial infection is there. If there is a deep fascia is involved, deep infection if it is present, and then it can be debrided, and then empirical antibiotic may be necessary. But if infection is seen late, means after 1 month, and adjacent to the site of infection, there are areas of erythema or multiple sinuses are present, then you should think about a possibility of a atypical mycobacteria. So atypical mycobacteria, most of the time, they may need a surgical drainage also, but simple drainage should not be attempted. They need to be excised properly. This AFE staining and atypical mycobacterial culture are sufficient to make a diagnosis. And surgical management, if it is medical management fails, medically they are treated with clarithromycin 500 milligram 2 times daily for 4 to 6 weeks. Long treatment is necessary along with amikacin 15 milligram per kg body weight. It can be given single dose per day or divided dose. and it should be, most importantly, is 4 to 6 weeks treatment is necessary. If it fails medical management, only then you should go for a surgical management. So when you do surgery, wide excision, almost all the sinus tract need to be excised, and they should not be approximated immediately. They should be allowed for granulation tissue to appear. Only then they need to be closed in a secondary intention by using a monofilament non-absorbable suture, which again prevents the chances of infection formation. Just to understand this port site infection properly, I have 3 case scenarios. I know Dr. Prabha is also having interesting cases later, but this is only just to understand the cases properly. A 38-year-old woman underwent diagnostic laparoscopy. On day 5, she developed redness, swelling, and purulent discharge from umbilical port side. Mild fever was present. On examination, erythema and a little tenderness was present. So, if I ask all the audience, what do you think about it? Is it a suture granuloma, or delayed mycobacterial infection, allergic reaction, or early gram-negative infection? Or
Sir, this was after how much period of surgery?
it is just 5 days after surgery, sir.
Then, sir, we cannot declare it as a atypical. It is a
Yes, it is just a early gram-negative infection. So it was, wound swab was taken, Pseudomonas aeruginosa was present, and it was sensitive to piperacillin and azobactam. Regular dressing and antibiotic was given for 7 days, and then the patient was completely all right. And one more patient we are having is 46-year-old woman who had underwent a laparoscopic myomectomy at peripheral hospital. 6 weeks later, she developed a small discharging sinus at the marsillator port side, and the surrounding induration was present, and areas of little erythema were also present adjacent to the site of port side. This considering the time and also the wound infection and the involvement of the erythema port side adjacent to the port side, there are 3 options are there: late onset bacterial infection, port side metastasis, delayed mycobacterial infection, or suture granuloma. So in this case, we can think about a delayed mycobacterial infection, which was confirmed by AAP staining and also culture. She underwent a complete excision of the sinus tract and received clarithromycin plus amikacin for 6 weeks, which healed completely. And we have one more patient, 54-year-old woman underwent laparoscopic removal of ovarian mass. 4 weeks post-surgery, she presented with a firm tender nodule at the 5 mm side. And initially, she had a signs of infection on antibiotic, but the discharge continued in spite of using the continuous antibiotic. So there's just a sinus nodule, but signs of induration and erythema were not very significant. Here again, we have 4 options: chronic bacterial infection, delayed mycobacterial infection, port site metastasis, or suture granuloma. Considering the patient was operated after for a ovarian mass and it was not healing following a antibiotic treatment, then surgical site biopsy was done. This biopsy showed high-grade serous ovarian carcinoma, and she was referred for oncological management. So just to understand the cases, I just mentioned the case scenarios also. So as a summary, preoperatively, hair clipping is preferred over shaving. Antiseptic, povidone iodine or chlorhexidine, if it is used, allow it for air drying, will prevent chance of infection. Antibiotic should be given 30 to 60 minutes before we take an incision. And if there are any morbidities like diabetes, or if any other comorbidities like infection, if it is present due to some other reason, they need to be treated before you take them for surgery so that surgical site infection or other type of morbidities are significantly reduced. Intraoperatively, maintain all aseptic precautions. Use autoclave at least ports if you're using a reusable one. Disposable, if it is possible, they are very useful. And maintain the complete OT sterility. Regular smoke evacuation during surgery and judicious use of energy source will also be helpful in preventing a surgical site infection. In the post-operatively, wound dressing and examination of these wound dressing after 48 hours will identify if any early signs of infection if it is present. If it is just a mild infection or superficial infection if it is present, antiseptic dressing and analgesic will be sufficient. But if there is a purulent discharge is present, erythema if it is present, then use the empirical antibiotics along with the local dressing. If there are any systemic symptoms are present, only then injectable antibiotics need to be. So whenever using injectable antibiotics, better to go for a culture and then narrow down the antibiotics once you get a culture sensitivity report. If you are suspecting any infection after 4 weeks, think about atypical mycobacteria. Then whenever you're using atypical mycobacteria, clarithromycin and amikacin are the drug of choice. Clarithromycin 500 mg 2 times daily, amikacin 15 mg per kg body weight. They should be given 6 weeks, 4 to 6 weeks. And if there is a recurrent or non-healing ulcer, sinus discharge is present, think about metastasis if it may be possible. So prevention protocol should be hospital driven. Proper protocol should be maintained and everybody should follow the protocol. If any infection is there, they should be suspected, and especially in India, atypical mycobacteria should always be in our suspicion. This is one case that sir wanted to discuss about it. Please go ahead, sir. You wanted to discuss about this.
This is again this morcellator site. Okay. And we came across this after around 6 weeks to between 8 weeks. And we treated it with the clarithromycin and this clarithromycin and ciprofloxacin. And this responded quite well. So my take is that response to the medical therapy is quite good, provided there is a compliance of the patient. Patient is taking the medicine regularly, and the source of medicine, it is not a hanky-panky company. That medicine is really good or not good. Then in these cases, the medical treatment chances are very good. And what Dr. Ravikant told, that excision, etc., that should be always secondary. It should not be primary. First, it should always be treated with the medical treatment. And one should not get, because there are some nodularity, some mass, so one should not get tempted to do incision and drainage of these sites. Once you put the incision and drainage on the first sitting, you will be further, you will increase the area and the chances of infection. And I think we go ahead, then I will.
Yes, yes. Yeah, I am finished, sir. Thank you, sir. Thank you so much for it. If there are any doubts, we can take the doubts. Otherwise, I am having MCQs if time permits. 10 questions are there. The audience can interact.
Yeah, sir. What I will like to add, that practice of tissue removal should be improved. When suppose something is there, say after ectopic or anything, this thing sometimes some people get tempted to remove it without simply from the skin incision, some structures. That should be stopped. It should be either through the say 10 mm port, or it should be put in the bag and then it should be removed. Once you do
That's
it,
very good, very point, sir.
yeah.
That is.
And another thing, if the mass is bigger, say dermoid or bigger cyst, then my practice is I prefer the colpotomy, this thing through colpotomy incision. Either put it in the bag or directly this thing. I don't know, Amias, or you can tell, the healing capacity of vaginal mucosa is much better than skin.
Yeah, I agree with you, sir. That's a very good way of tissue retrieval. One comment I would like to make on Ravi sir's presentation. Of course, it covered every aspect of it. Two things I want to highlight is the use of linezolid along with clarithromycin has been found to be effective. Just a note I'm just making. Second thing is when all medical treatment has been implemented and you have a discharging sinus, how we tackle it, I'll just mention a trick in our practice. What we do is through the opening of the sinus, we inject concentrated methylene blue, about 1 or 2 cc of it. And after we inject methylene blue, it enters into every recess of the sinus tract. And then when we start excising the sinus with the elliptical incision, anything that is blue has to come out. Right up to the sheath. Generally, these sinus tracts extend right up to the sheath. So that's how we tackle these things. But of course, we don't leave them open. We are using primary closure of after the excision with deep-seated suture in the form of 2,0-ethylone.
Yes,
Okay,
sir.
so that is how we do
Yeah,
it.
but like literature suggests to go for a secondary suturing just to because
Yes, sir. Yeah,
these
yeah.
are very resistant
Practically, we have found it.
infection. So the
Yes,
first
sir.
treatment should be complete and clear. Most of the time they respond to medical
Yeah.
management for long-standing treatment. But many a time what happens after once the wound heals, the patients will stop taking the medications. So then they think that
Yes.
it's already healed. Then after they stop for a week or so, then again it will reappear. So that is a major challenge. As sir was mentioning that a patient compliance is equally important in these cases. Though the incidence is less, but they are more disturbing to the patients. Even a 1 or 2 patients will be
Yes.
very big headache. And while doing the beginning itself, a complete treatment will be used, will be better than recounseling, than taking them once again and again for surgery.
Yes, sir. Thank you, sir.
Yes,
Thank you, sir.
thank you, sir. It's very true and very elaborative discussion about the port site infections. Always Ravi sir makes it very much interesting about the cases by putting the case and all. Thank you, sir. Thank you, Vijay sir, for giving your so much of experience in a very short much of time. And thank you for agreeing and joining this webinar and giving us, so much of information about your vast experience. Thank you, sir.
Yeah.
Thank you, Dr. Prabha.
Thank you, sir. Thank you, thank you.
Maybe after your case, I'll take 10 questions are there. After you present the case, then we'll see.
Yes, sir. I will also finish fast.
Yes.
Yes.
Yeah, thank you, Ravikant sir, and thank you, Vijay sir. Moving on to a case presentation, the chairperson for case presentation is Dr. Manjunath. Manjunath sir, are you there?
I think he is not there. No, one of
Yeah.
let the Ravikant sir or Amaya, who is free now, will
Yeah.
chair the session. Either Ravikant.
Yeah, surely.
Yes. Yeah.
Yes. So the case presentation is next by our chairman of endoscopy committee, Dr. Prabha Desai, ma'am.
Yes,
Yes,
Dr.
sir.
Prabha is very
Sir,
dynamic.
No need to introduce so much of the thing because it is
Yeah, no,
already there.
everyone aware of Dr. Prabha Desai.
Not.
She is very dynamic and she is a consultant at LY Desi Memorial Multi-Speciality Hospital, Gadaga, Karnataka. And she has many awards: Golden Jubilee Award, Mumbai 2002, IAG Excellence Skill Youngstar Awards. Even I was there when she was receiving the award. And the first prize, best poster prize in Kisar 2019, the recent one. And the best academician award of the Gadag OBG Society in 2015 and 16. Foxy Pillar of Progress Award by Solapur OBG Society. So she has a lot of laurels and a very good speaker as a whole. And she is a lot of showing interest, and she has many publications, national interest, and she has conducted various workshops, and she is also running a IAGE and RGHS training courses also she is running. So that's a very important. Go ahead, Dr. Prabha now.
Yeah, thank you, sir. Without wasting much time, I will share my screen. So actually, I just wanted to give the opportunity to the other endoscopic surgeons to present on some their interesting cases, but I think most of them were busy and not getting the time for this. So that's why I thought this time I would only present. So actually, only two cases I am highlighting here. What we used to do during our PG period by open technique, now we have shifted all those techniques to the laparoscopic. So there is no limit for laparoscopic surgeries. So here now we are away, means that port site infection and in your sterilization techniques has been discussed so thoroughly. So I thought that little bit of our practical things or day-to-day surgical skills, we will discuss on that. So this is a 34-year-old para to living 2 with day 14 of elective LSCS. At 39 weeks of gestation, LSCS has been done. And one fine day, she has called her consultant in the morning hours, early morning, that she is having a fresh bout of bleeding of about a liter of bleed she had, and she had a fainting attack and she fall down in a toilet actually. And then they have brought to the hospital, to the primary consultant's hospital. They were given tranexamic acid, carbopros. There was no any intrauterine collection or nothing. They have transfused one PRBC, given her RL and all, stabilized her, and suddenly that bleeding stopped. There was little bit of collection, but it was not a intrauterine, it was not any, I think it's a case, screen has been shared, right?
Yeah, screen share, you can make it slideshow.
Yeah,
Make
yeah.
it
So
make it
it
slideshow.
has been, so when we have done the scan, there was actually a lot much of vascularity was seen in the myometrial region, and we thought of it was an emergency. We don't have any intervention radiology unit in our city. That's why I shifted her for bilateral, actually for
Prabha, make it
laparoscopic.
slideshow. Full screen it will come.
Yeah, wait, sir. Yeah. Okay,
Yes, yes.
fine.
Yes, yes.
Yes, sir. So I have made her, I have posted her for laparoscopic internal iliac artery ligation. Till now, we used to do laparoscopic uterine artery ligation at the origin, but this case, we have done a bilateral internal iliac artery ligation by laparoscopically. You might be seeing that the uterus is densely adherent and it was ventrofix, completely ventrofix, even though you can see that there is a suture line also is still there. I tried to release it, but it was difficult to release at that site. And the uterus was still 14th day of LSA, so it was sub-innulated uterus. It was not proper involution has not completed. So we decided to go for internal iliac ligation. It was on the right, left side. We can, sorry, it is on the right side. Yeah, we can go by anterior approach. Okay, by anterior approach, you can see here the ureter on the left side. This is on the left side, the ureter I could make out. Then this is the external iliac artery and the vein. Now we have to search for the internal iliac artery, complete internal iliac artery. See, what are the technical hurdles here is, while doing a open internal iliac ligation, how we go, by fingers, we dissect bluntly and then go there. Here, during while laparoscopic approach, even though we can see it properly, but because it was ventrofix uterus, we could not got us such a free space to move our instruments. Okay, so here we have tied the uterine internal iliac artery with at how we do, and in open cases, the same thing we have tied with uterine internal iliac artery by at two sides, okay, so that we will achieve a complete blockage of internal iliac artery. Okay, so as everybody knows, and if we see on the right side, this is on the left side. Right side, it was difficult to go anteriorly because of the ventrofix uterus. So we had a posterior approach. Okay, for lifting of the such a bulky uterus, we use a lever retractor, which has become one of my famous favorite instruments to lift the bulky uteruses. So here this is a. Initially, we thought of we will clip it where the uterine artery at the origin. See the size of the uterine artery at the origin. It is too much increased because of the as it is a obstetric uterus. Okay, it's a peripartum uterus. So, but the whole purpose of, because we don't have an exact location where the atriovenous malformation or your AV fistula has happened, we don't know. That's why again we have shifted and then done the internal iliac only. Okay, as you have seen on the same side, and then we have taken out those clips afterward. So somebody was, discussing with me, how come you take out those clips once you apply? But the thing happens, you can aramse take out the clip by pressing it to the proximal part of the loop of that clips. So after that, we tried to evacuate little bit of clots, whatever there inside the uterus. But actually, our cannula also was not going up to the fundus because it was too much of elongated cervix, and because she was previous two LSS, previous one LSS, of course it is para to living two. So we could not reach up to the fundus. Whatever clots we can take out, we have sucked out, and the remaining things within next 15 days she settled, and she's doing well now. So this is one more case actually where case of 30 years old gravida 4 para 3 living 3 with previous 3 LSAs presented with history of missed abortion, 3 months back. And she told that it was a missed abortion, but actually there is a history of MMA when we are evaluated by, and with the continuous PB bleeding, she approached us. And the uterus was very bulky. She has passed actually the only fetus, and the what all remaining is RPOC. That was a placenta which has been stuck into the at the niche site, and it has created into the niche was a complicated niche which has formed its way into the anterior myometrium like a pouch of a thing, and the whole the placenta was into that pouch of the niche. Okay, and she has on ultrasonography there was enhanced myometrial vascularity. Lot of vascularity was seen in the myometrium, and there was a periuterine adhesions also suggestive of ventrofix uterus. So on histoscopy, on histoscopy, once I just wanted to see whether I can take out any part from the histoscopy, whether we can completely evacuate it by vaginally only. This was a highly vascular products of conception, and the cavity was fully completely filled with the products, but I could not see I could see whatever is inside the cavity, but majority of the products was in the niche area. And once I took out the scope, the patient histoscope, the patient started bleeding torrentially. So we put the Foley's catheter in the endometrial cavity, that is the 16 number Foley's, and we have inflated it so that I could achieve the hemostasis. And again, we decided to do the internal iliac artery ligation at the origin by laparoscopic approach and take out all the products by laparoscopic way. See, this is also very bulky uterus. She has, it was actually more than 13 weeks might be, because whatever we have taken out was only placenta here. So this is on the right side, left side, where we thought this is actually a very vascular broad ligament area. So I thought of let me go to the left side of right side first rather than approaching the left side. So on the right side, anterior approach, I could get the uterine arteries at the origin. Okay. So this is a site of incision to approach for uterine artery at the origin. I will just move little forward here. Okay. So here on the medial side of the first branch which internal artery gives to the is a uterine artery, and it has been ligated at its origin. So same thing on the left side, I tried to go by anterior approach, but it was very difficult as you can see so much of dilated things. Vascularity was very high. So we went posteriorly at the triangle between the ureter and here and the, okay, just above the ureter, we have opened the space. Okay. And through posterior approach, I could, okay, on the lateral to the uterine ureter, dissected the space. See, this was a very chronic RPOC. So it is very difficult there. The edema, tissue edema will be more, inflammation will be more. So getting the planes is little difficult in such cases. With a meticulous dissection and gentle handling, I could ligate this. Here we have done actually ligated the 2L, that is a temporary internal, sorry, what happened? I don't know, temporary internal iliac artery ligation by its origin. Okay. And then we could, okay, here we could take the incision over the anterior surface of the uterus. Prashant, it is not playing. Something went wrong. Here again, we have took the,
Wait until last.
so just for technical hitch, here we have taken the incision over the bulge part of the lower segment of the uterus after dissecting the bladder completely, and then taken out the whole of the products of conception. Mainly it was the placenta, and then how we repair the niche. The same kind of lower uterine segment has been repaired, and the tubectomy has been done for her, and then we could save her, and she received 1 point of blood also, because actually we never think that because of distension of the uterus with the hysteroscope itself will trigger the active bleeding from RPOC. She bled a lot on table. Here something has went, this problem, this further video is not playing here. Few seconds we need to wait.
You can
Yeah.
just
Yeah, so
escape it, then make it small, minimize it.
Okay. So it is rotating. I don't know. It is.
You can go to the direct to the source. And
Yes,
then
it is my own laptop, but how to escape? Escape?
Madam, please
Yeah,
stop the sharing.
Yeah, I will close
Reshare
the
it.
program.
Yes.
Reshare it, ma'am.
No, wait.
Yeah.
Yeah, please reshare that.
Yeah, wait. It's almost only hardly 2 minutes, not only 2 minutes also. Huh? Maximize. But share, I should share, no?
Yeah, it is shared. It is shared.
It is shared,
Has
ma'am.
been shared? Okay.
Yes, yes. Make it slideshow, ma'am.
Yeah.
Just go to that slide, ma'am.
Okay. After ligating, we have power and battery. Something is showing. Okay. Something beyond this, there is some technique. Power and battery, something it is showing. Energy saver is on. We'll have energy saver.
No,
Hang ಮಾಡಿ. It's okay. I think we are getting late. Restart the program. Close the
Hello. Hello,
Yeah,
Prabha.
okay, no problem, madam.
Huh.
So we have
Prabha, no, I just
tell
no, no.
orally, it is already
Correct.
late.
You can already tell.
Yeah,
No,
yeah.
that's okay.
So
That's
just
okay.
why
I just wanted to say something, Prabha, about
Yes,
the
ma'am.
second case that you had. It is very interesting case. I thought that the second case was an early placenta accreta actually. The one which you said, na, that it was
Yes,
into the
sir.
myometrium. So it is a very classical description of a placenta accreta which was caught early because she went for a termination.
Yes,
And
ma'am.
then it landed up with the torrential bleeding. So
Yes, ma'am.
it was very well managed. She is very, very fortunate that she avoided hysterectomy.
Yes,
So
ma'am.
actually, and then also blessing in disguise that the pregnancy kind of got, terminated early. Otherwise, later in pregnancy, definitely she would have had a hysterectomy and more morbidity. So
Yes,
that was
ma'am.
very
Yes,
well managed. I just wanted to say it did sound like a very early placenta accreta. Yeah.
yes, ma'am. Sure, ma'am. It might be because of niche area, it is thinned out and then that will cause the problem. So I think this laparoscopies has a minimal invasive way, but it will save the lives if we take the decisions on time and do the proper procedures on time. Thank you, ma'am.
Dr. Prabha,
Yes, sir.
I will like to put one comment.
Yes,
Uh,
sir.
I am just flattered with presence of mind of your mind in such a difficult situation. You took a decision. Your technique is excellent, but more than that, your timely decision of putting the Foley's inside and keeping buying the time, I really appreciate that. Otherwise, when we get such situations, we ourselves we get this thing and we get tempted to
Sir.
go for hysterectomy.
Yes, sir.
Correct.
Yes,
I,
sir.
I
Correct. Yeah, I agree with that. Yes, yes.
Yes, sir. Yes.
Very, very courageous of you, and I agree fully. I agree with Dr. Vijay. Yes, very, very correct.
So
Yes.
actually, I wanted to show that Foley's, once we cut open the anterior, this thing, that polish will pop there. And once we take out all the products, then how the bleeding has stopped. That was very nice thing. But somehow it is not, it is sucking there and then it's just ringing. But I will share in group, no problem.
Yes, it is very nice, madam. Thank you.
Yes, yes.
And why in the first case the clips were not sufficient, madam? Why did you remove the clips
So
and put
actually,
the
no,
stitches?
we put that clip has been put on the internal uterine artery at the origin. So then I thought of, we don't know the exactly where it is that it is better to, rather than only uterine artery at origin, better to ligate the internal ileac. And that's why I just taken out and then I put that side also the internal iliac. Because first I could trace, because it was a posterior approach, I could trace the uterine artery at the origin earlier, and then I went posteriorly, then I could trace the internal iliac artery.
Okay, okay. You didn't want to put the clips to the internal iliac artery.
I don't know, sir, because it is too, it was a postpartum uterus and
Okay,
it was
okay,
very
okay.
big. And
Don't want
sometimes
to take a
we
risk
don't,
also.
yes, yes.
Is that done actually? Is the clipping done for internal iliac? I was not aware. Is
So
it done?
will
Is
be
it done?
for uterine artery we do, ma'am.
That's what. Uterine artery is kind
Because
of
this
well
is
mentioned
the only
everywhere
post,
and effective. Internal iliac. Yeah.
postpartum, but we, if we don't want, we can take out it safely also, actually, with the good, yeah.
Yeah. Okay.
Yes, ma'am. Thank you, ma'am.
Thank you.
Dr. Prabha,
Yes, sir.
before we close, I will like to say that all of us we are getting so much of experience on isthmosil, different types. This was a great this one. And I have many, then everyone, Dr. Ravi, that we can conduct a conference only on isthmosil.
Yes, sir. Actually, sir,
And
being this, I have taken the initiative of endoscopy as a endoscopy committee chairperson. This year motto is the same, sir. I am carrying every 2 monthly in different cities of Karnataka about the post-cesarean complications and its role of endoscopy in its management. So first workshop we are doing in Raichur, sir, in 7th September, where we have divided all the topics on that only, like 4 5 lectures on these all post-cesarean complications and its management, and we are showing on histoscopy and laparoscopic simulators how to close those isthmosil and all. So that is going on, and we are publishing soon the focus on post-cesarean complications and role of endoscopy. So
and another
yes, sir, it is.
another topic which is again becoming intriguing is the AVM.
Yes, sir.
So much
Correct.
of AVM diagnosis.
Yes, it's I don't know, it is furious means how we are diagnosing it orally or whether it is really exists. We
Yes.
don't know. AVM are over-diagnosed nowadays in RPOCs actually.
Yeah.
Yeah,
In RPOC, it becomes overdiagnosed. But
over-diagnosis.
otherwise, there's
But
such conditions are there, then it
yeah,
will be
in
tackled
istomosil
differently.
and all, it is existing, sir. Yeah, sometimes pseudo aneurysm and all also we have managed 2 cases of pseudo aneurysm in post-cesarean bleeds where they come with like a tap like a bleed and there will be nothing to see in the endometrium or anything. So those cases we manage with interventional radiology actually. Here it was we done with laparoscopically. Yes, sir. Thank you, Ravi, sir, for sharing my session in a short
Thank you.
notice.
Thank you, madam.
Talk
Just
also.
I just had a 10 questions. If the audience are interactive, you can stop sharing, Prabha.
Yeah, sorry. Where? Yeah, wait. Yes. Yeah,
Yes.
stop sharing.
Uh,
Yeah.
It is just interactive, and the questions are very simple. If they interact, it will be nice.
How they should interact?
Like in the chat box,
They can open and then tell, no problem. Yeah.
They can write it in, they can write their answer in the chat box, A, B, C, D, like that.
Yes, yes.
Yeah. The most common organism causing early port site infection: Mycobacterium fortietium, Staphylococcus aureus, Mycobacterium shilloni, Candida albicans. Very simple question.
Yeah.
Just to make the webinar more interesting, that's all.
Already answers are there, sir.
Yeah.
Everybody is writing a correct answer. It is B.
B, yes.
Yeah.
I'll just give 10 seconds and then I'll close. I'll go to next questions.
Yes, sir.
Yes. Many are answering B as a answer. Yes,
Yeah.
nice. Answer B is the right answer. Staphylococcus aureus is the common. Late onset port site infection are commonly due to E. coli, Mycobacterium fortietium, Staphylococcus epidermidis, Pseudomonas aeruginosa.
10 seconds.
So again, it was
B.
Very simple question. Just to make it more interesting, I kept very simple
Correct.
questions.
This quiz
Yes,
committee
answer
is
is
more happy to see your questions. Yes, sir.
Yes. Correct answer is
B.
B. Yes, very
Yeah.
nice. And which preoperative measure reduces the surgical site infection most? Shaving hair at the night before, clipping hair just before surgery, applying povidone 1 minute before, and prolonged fasting before surgery.
Again, yes. It's again B.
Yes, B are taking the most of the answers, I think.
Okay.
Thank you. It is clipping the hair. It is preferred, and it should be done 3 hours before the surgery, and shaving should be discouraged. Povidone iodine, at least you should allow
3
for 3
minutes.
minutes or air drying. Yes. A recommended timing for surgical antibiotic prophylaxis: 2 hours before, 60 to 90 minutes before incision, within 30 to 60 minutes before incision, or after skin closure.
See, yeah, see, already everybody has answered.
Yes, yes,
Yeah.
yes. That's very nice. So answer C, 30 to 60 minutes before the incision. Very nice. Persistent port site infection responding to not responding to standard antibiotic. Should have a suspicion of MRSA,
Yeah.
allergic, atypical mycobacteria, and fungal infection.
Might be MRSA. A.
In India means we should think about something different answer.
Atypical mycobacteria.
MRSA is also possible, but thinking about the
C.
not respond to routine antibiotics, definitely we can go for atypical mycobacteria, but MRSA is also a very good response.
Yeah. I think A and C here.
A and C both are very good response. We should
Yeah.
be practically considering, we should both think about resistance also and the atypical mycobacteria. The drug regimen of choice for atypical mycobacteria: amoxicillin, clavulanic acid, metronidazole, clarithromycin, amikacin, ciprofloxacin, gentamicin, vancomycin, piperacillin, and tazobactam.
Yeah.
So drug of
everybody's-
yes,
yeah,
yes.
B. Sir
B,
likes the B option.
clarithromycin, amikacin. As I didn't notice that, but
Yeah, it's clarithromycin and amikacin.
clarithromycin, amikacin is preferred answer. Is a drug of choice recommended by WHO. Yes, very good. Which intraoperative factor most increases the chances of increased risk of port site infection? Short operative time, excessive use of monopolar cautery, use of disposable trocars, smoke evacuation.
B.
C also.
Mm,
B and C, sir.
Only B.
Which increase the
Use
risk
of
of
monopolar
port site
info-
infection?
Excess use of monopolar.
Excessive use of monopolar. Yes. Disposable trocar reduces chances,
chances.
and
Yeah.
smoke evacuation also
Should
reduces
not
the chances.
reuse it.
Yes. The gold standard for diagnosing atypical mycobacter infection: gram staining, ZN staining, and mycobacter culture, ultrasound, histopathology.
ZN.
Atypical. Okay.
Yes, yes. Atypical mycobacter means ZN staining plus mycobacterial culture.
Okay. B.
Management of mild port site infection without discharge in otherwise healthy patient: IV antibiotic, local wound care and observation, surgical debridement, and oral antifungals.
It's again B, sir.
B.
Yeah,
I think my
local
bad.
care and observation.
I didn't observe that. Most of the answers are coming in B.
B.
Yes, B is the right answer. Yes, thank you. Last question. Port site metastasis should be suspected when a pain and tenderness occurs within 3 days of surgery, firm nodule 4 weeks after oncological surgery and does not respond to antibiotic, clear serous discharge after cholecystectomy, and itching and rash over the port site. Yes, again, I think most of the answer I put it as a B only, but that I didn't notice.
4 weeks after oncological surgery.
Yeah, please answer, sir. Sir is raising the hand.
No, I will ask one thing. Once we have finished it, have you finished?
Yeah, it is done, sir.
Yes, sir,
That was the last question.
One very interesting questionnaire you have made of the practical problem, saving of the area. So that is definitely just on the day prior. If we nowadays we are the educated patient, if we ask them to do a home saving at 2-3 days or before that, in a planned cases, which is better or hair clipping will be better?
So clipping is painful, no? Nobody will be accept. Nobody will accept.
If
So
I-
that's why there are studies. They tell that to put that hair removal creams.
yeah.
Yeah,
Yeah.
so that just we don't want that pore to be opened. The hair root follicle pore should not be opened.
Dr. Prabha, suppose it is a planned case. I have planned it. It's not an emergency. I have planned some case before 7 days or 5-7 days. Then can I ask them 2-3 days that before 2-3 days either they can do with the hair remover or they can do self-saving.
Hair remover is
Hair
always better.
remover is
Hair remover or
always better.
clipping, I don't know.
Clipping
Like
is better.
clipping is preferred. It is widely accepted even for open cases also. And many studies recommend clipping over the shaving.
Mm. Yes, sir.
Hello.
Yeah.
Yes, madam. Yes, madam.
Yeah, I'm Dr. Soumya here.
Yes,
Yes,
ma'am.
Sir, I would like to know one thing. Actually, regarding the treatment for atypical mycobacteria, it's always the combination of the 3 drugs. All evidence-based this thing, they tells that it's always the combination of 3 drugs, not the 2 drugs. Either it should be claribid, cotrimoxazole, or levofloxacin, or with amikacin, or with rifampicin, something like that.
But here the study recent WHO, I am quoting WHO 2025, madam, 2023. Based on that, atypical mycobacteria 4 to 6 weeks, and should be amikacin and like other regimes are there, but this is the most preferred regime.
Actually, I had few cases of atypical mycobacteria, and in my personal
Yes,
experience,
very nice, madam.
that
Please share, madam.
time, like I contacted almost all the infectious disease specialists in the world, actually, because one of my very close cousin had it. That time, like all the studies they were showing, even I went through the studies, it was showing that it should be a minimum of 3 months. That's what they told. Combination of 3 drugs, and it should be a minimum of 3 months. Suppose over a period of 3 months, after 3 months or 6 months, if they get one more nodules or anything over the skin, again we'll have to give it for 9 months or something like that.
Then surgical excision is preferred, madam. Wide surgical excision.
Yeah,
and,
along with the surgical excision, we need to give the drugs for longer time, sir. That's what they told, and even studies are there.
Okay. Yeah, that is very nice, madam, because the
Amikacin for
practical
how
experience
many
is
days?
totally
Let me
different.
share it in the group, sir, later.
Sure, sure, ma'am. I will be
There are
happy.
guidelines are there, but guidelines are there to help us. But practically, what we do, how we come across, how
Actually,
we
to
heal
tell
the
you the
patient.
truth, my husband had appendicectomy. He had atypical mycobacteria. We find it very difficult to diagnose
Yes,
this.
madam. They are very
Maybe we took
resistant.
nearly 2 months to diagnose that. Then I contacted many people all over the world. That's how I got a very good clarity about the treatment part, sir. I will share it in the group again.
Yes,
Sure,
thank you
sure,
so
ma'am.
much, madam.
Yeah, yeah.
Okay. Okay, sir. Thank you.
Thank
Thank
you.
you, sir.
Thank you so much, ma'am, for giving your experience.
Yeah.
Yeah, sharing your experience.
Yeah,
Yeah,
okay.
Priscilla.
Yeah. I would like to extend a heartfelt thanks to all our speakers, Dr. Amaya, Dr. Ravikant Gaura sir, and Prabha madam, for presenting such an interactive case. I would like to thank all our chairpersons, Dr. Asha madam, Dr. Vijay Nahata sir, to be here, spending their time and also sharing their valuable insights. It was indeed a very good interactive session. Thank you all the participants for making this session more interactive. We hope to see you in the next webinar or next month. Thank you all.
Thank you,
very
sir.
much.
हमारा तो पैसा वसूल हो गया टाइम इतना जितना हमने लर्निंग किया है वी हैव लर्न with Dr. Ravi, Amya, Prabha, and recently what Dr. Mani. She really
Soumya
shared
Mani.
the practical experience.